Alright guys, welcome to my final presentation. My name is Yutong Zhao, and the title of my project is Towards Optimal Margins in Prostate Radiotherapy. My supervisors are Shahin, Martin, David, and Simon. So first of all, I'm going to give you a basic introduction about the background of the project. This project is aimed to the radiotherapy for the prostate cancer. The prostate gland is a gland position in the inferior direction of the bladder and anterior direction of the rectum. It has a proximity size of 2 cm by 3 cm by 4 cm. And the radiotherapy is a widely using treatment method for the cancers. It can kill or disable cancer cells, destroying the DNA structure of the cancer cells. At the most of the time, the radiotherapy is performed by using the linear accelerators over here. So for the radiotherapy, it has many advantages. It has ability of eliminate invisible microscopic disease at the periphery of the tumor. It could treat tumor sites which surgery cannot reach. It could preserve patients' organs such as prostate in the prostate cancer. So the prostate cancer tumors are lateral acting tissues, which means it is demonstrating an increased survival rate at low doses and significantly greater toxicity at higher doses. And for the lateral acting tumors, especially for the prostate cancer tumors, we prefer a prescription with a small number of fractions and large fraction sizes. The large fraction sizes here means we're going to deliver a relatively large radiation dose for every fraction. And this may well result in a more severe side effects, such as radiation proctitis or the lymphedema. So why there are side effects in the after the patients accept the radiotherapy? That's basically because there are some radiations to the OARs during the treatment. And the reason why there are radiations to the OARs is because there are some uncertainties, especially the geometric uncertainties. And the most of uncertainties actually is contributed by the OAR's motion. So in this project, we aim to create a safe margin for the bladder and rectum to cover possible OAR's motion. In this way, we could put uncertainties in our consideration when we create the treatment plan for the prostate cancer patient. And therefore, we could protect the OARs from the unnecessary radiation dose. At the end, we could improve the treatment outcome. So the aim of the project is quite simple. It's just generating a planning organ at risk volume margins for the bladder and rectum in the prostate cancer radiotherapy. And the PRV margins here means the tissue volume, which accounts for geometric uncertainties for OARs in the radiotherapy treatment process. The steps of the project are going to be following. The first of all, we're going to measuring and describing the bladder wall and rectum wall interfraction motion. And next, we're going to, based on the measured data, analyze the rectum wall motion pattern and segment the rectum according to the rectum wall displacement degree in different rectum region. And third, we're going to find the wall position distribution pattern for both bladder wall and rectum wall. And next, designing reliable PRV margins generating recipe. In this way, we could generate bladder and rectum PRV margins by using the data we have, so using this recipe. And finally, we're going to design a validation method to test the performance of PRV margin and picking the qualified PRV margins through using the validation process. There are two softwares I used in this project. The first one is called MEME, which is a radiation oncology tool. So most of contouring tasks for the bladder and rectum are done by using the MEME. The second one is called Pinnacle. The Pinnacle is a commercial computerized treatment planning system. In this project, most of the tasks involved radiation dose investigation were performed on the Pinnacle. And for this patient, we investigated 16 patients' DICOM information. All DICOM data are currently provided by the Genesis Care Field Stanley Hospital. For each of the patients, the information will include 1 fraction CT images, 5 fraction CBCT images, DICOM RT structure site, and DICOM dose files. Next, the method. So before everything, we have to create the contours for the bladder and rectum. So for the bladder contours, there are 15 patients. CBCT bladder contours are qualified as studied cases for this research. 1 patient's CBCT bladder contour have not met our demand owing to its low CBCT image resolution. For the rectum, 13 patients' contours are qualified for the project. 2 patients' rectum contours are inaccurate going to low CBCT image resolution. And one patient has an excessive huge rectum volume in CT scan relative to the CBCT scan. After we having the bladder and rectum contour on the CBCT image, we're going to transfer these contours from the CBCT image to CT image through using the image fusion process. The image fusion procedure is going to be based on the 3 fiducial markers inside the prostate gland. And finally, we can have a CT image series, which contains all the CT organ contours and CBCT organ contours. Here's an example shows over here. So in the figure over here, we have 5 fraction CBCT bladder contours, which are pink contours over here, and the CT bladder contours, which is yellow contour over here. And then we're going to generate 2 extra contours. One is called bladder union contour, which is a contour contains all 5 fractions CBCT bladder contours. It's displayed in the green contour over here. And bladder intersection contours, which is a contour composed by the intersection region of 5 fractions CBCT bladder contours. That one is a light blue contours over here. In this way, we can evaluate the biggest bladder or rectum wall outward displacement by just simply measuring distance from the yellow contour to the green contour. And we can also evaluate the biggest inward displacement by simply measuring distance from the yellow contour to the light blue contour. And for the rectum, the procedure will be the same. Then we're going to have a small investigation about the bladder and rectum position distribution. So first of all, we're going to choose a transverse plan, and then we're going to set a coordinate system on this transverse plan. And third, we're going to measure the distance from the CT organ contour to the CBCT organ contour, which is the pink one over here. So if it is outward displacement, the value will divide to the maximum outward displacement distance in that direction. For example, we measure distance here is 1.22 centimeter. We're going to divide this value to the biggest value over here, which is 2.41 centimeter. In this way, we could transfer all the distance value to the percentage values. And finally, we're going to repeat this process for all patients, and for all the patients, at least 3 plans need to be chosen and measured. And then we could generate a histogram, which contains the information of the bladder and rectum wall position distribution. The x-axis of the histogram represents the percentage organ wall position, which stands for the proportion of the biggest organ wall displacement distance. When x equal to 0, that stands for the position of the CT organ position. When x equal to 1, that stands for the position of the furthest CBCT organ wall position. And the y-axis stands for the number of times CBCT organ wall appearing at that position, which is the frequency. After we having the histogram, we will calculate the mean value and the standard deviation to generate a normal distribution line chart. This line chart is helping us to determine the width of the 90% possibility interval, which starts from the 0. And we set 90% possibility interval as an area from 0 to 8, which means 90% of the organ wall motion will fall in this area. If we want to create a PRV margin which could cover at least 90% of organ wall outward motion for 90% of patients, which is 14 out of 15 patients, first of all, we're going to have a list. And that list contains all the information we have, the displacement distance values over here, and the slice numbers over here. We're going to calculate the average number for this patient on the aspect of the displacement distance. Then we're going to repeat this process for all the patients until we generate the list B. Next, we're going to multiply these values with K, which is 90% possibility interval. In here, we assume K equal to 80%. So we generate the list C. Because we generated this PRV margin for 90% of patients, which is 40 out of 15 patients, so we're going to pick the second largest value here to be the margin width in the posterior direction. And then we're going to repeat this process for all the directions until we get this final PRV margin size. And in this project, we also create some validation parameters to help us test the performance of the PRV margins and pick the qualified one. So the first parameter is called original coverage. Original coverage equal to the value of how much percent of CBCT Bony unit volume would be covered by CT organ volume. The formula is given by over here. So if a patient has a pretty small value of the original coverage, that basically means these patients experienced a relatively huge rectum wall displacement in their treatment. Next one is called the effectiveness. Effectiveness of PRV margin represents the percentage of useful PRV margin volume account for the entire PRV margin volume. The useful PRV margin volume means the PRV margin volume which would cover all the motion. So if a PRV margin has a smaller value of effectiveness, that means this PRV margin may be expanded this width in wrong direction. The third one is called outward coverage. The outward coverage represents how much percent of the outward organ motion area could be covered by this PRV margin. The formula is given by here. It's a quite straight parameter. And here is a small demonstration about how we use the outward coverage parameter. First, we can assume that the Y region stands for the CT organ volume. The purple and the blue region stands for the Brownian union of 5 fraction CT organ motion. The purple region stands for the region where 90% of organ outward motion will appear in. And in this way, we can see the purple area should be K times the purple plus blue area, the K equal to 90% possibility interval. And we got a conclusion, which is margin which could cover at least 90% of the organ outward motion equal to the outward coverage of this margin should be greater than or equal to the value of the K. So when we're validating the performance of the PRV margin, first of all, we're going to calculate the outward coverage for all the patients for this PRV margin. We generate a list over here. And then we're going to rank the patients according to the value of the outward coverage. If this PRV margin is aiming to cover at least 90% of organ motion for the 90% of patients, which is 12 out of 13 patients, we're going to pick the second smallest value over here, which is number 12 out of 13 value over here, to be the value of the validation result for this PRV margin. We can assume that if this margin is bigger or equal to the value of the K, then we give this PRV margin as pass. Next, result and discussion. The 4 figures here shows the result of the bladder and the rectum motion measurement. And as we can see for the bladder wall displacement in the posterior and anterior directions actually are much larger than other directions. But for the rectum, 4 directions displacement actually looks a little bit similar. Here's the result about the bladder and rectum wall position distribution. Histogram here shows the bladder wall distribution, and histogram here shows the rectum wall distribution. And we can see they are both similar to normal distribution. So we calculate the mean number and the standard deviation for both organs. And we find the mean value for both bladder and rectum are approximately equal to 0.5. The standard deviation for bladder and rectum approximately equal to 0.2. Therefore, we generate a normal distribution line chart with a mean value of 0.5 and sigma 0.2. And then we calculate the K value, which is 90% possibility interval from the 0. The K should equal to 0.77. And according to our PRV generating recipe, we generated 5 different PRV margins for the bladder. All these PRV margins has its own aim. So for the PRV5, 4, and PRV1 is 3 PRV margins, bladder PRV margins actually generated for all the patients. This PRV4 is kind of special. It's a uniform bladder PRV margin based on the margin width in the posterior direction of the PRV5, which means PRV4 has the same margin width in all directions. The PRV3 and the PRV2 are generated for all patients except special cases. The special cases is 3 patients we picked in this project because at least 1 fraction of their CBCT bladder witnessed an enormous bladder volume expanding. And here is a validation result. In this presentation, we only have a look at our coverage value over here. So apparently for the PRV5 and for the PRV3, their result is both higher than 77%, so we gave it a qualified. But for the PRV2 and the PRV1, their value is slightly lower than 77%. But in this project, we believe a difference between 2% or 3% is totally acceptable. The PRV4 is kind of special. It's a uniform PRV margin. So if we have a look about the margin volume of PRV5, PRV4, and PRV3, it's not difficult to find that PRV5 has the biggest margin volume, PRV3 has the smallest margin volume. However, on the aspect of the mean value of the outward coverage, the PRV5 got the biggest volume, the PRV4 got the smallest volume, which means compared with the PRV3, the PRV4 has a bigger margin volume, but it actually covers less. So we got a conclusion, which is if the condition permits, it's always better. Using the uniform PRV margin is not our first choice. Here is a list about the final bladder PRV margins, all in centimeter. Okay, the real problem about this project is the rectum. The rectum is a kind of complex organ because rectum has different displacement degree in different regions of the rectum. Normally, the rectum will have a larger displacement in the superior part of rectum. We will have a smaller displacement in the lower part of the rectum. So that's the reason why we want to segment the rectum before we give them the PRV margins. And according to the position of the pubirectals over here and all the rectum flexure, we segment the rectum into upper and lower part of the rectum. And in this project, we further segment the upper part of the rectum into superior and middle part of the rectum according to the position of the half point of the upper part of the rectum. In this way, we have three different options, three different methods to generate and segment the rectum. In the first method, method 1, we don't segment the rectum. We just give rectum one PRV margin. In the method 2, we segment the rectum into upper part and lower part of the rectum and give it 2 PRV margins. In the method 3, we segment the rectum into superior, middle, and lower part of the rectum and give it 3 different PRV margins. So which one is better? We get a comparison between the method 1 and method 3. And for the sake of comparing these two methods, 2 PRV margins were created by using 2 methods separately. The margin volume of 2 rectum PRV margins are approximately the same for the sake of fear. On the aspect of the effectiveness, under the approximately equalized margin volume, the effectiveness of method 3 margins for 9 patients are larger than that of method 1 margin. The maximum increment is 10%, which is not a small number, and the average increment is 5.19%. For the rest of the patients, the effectiveness value of method 3 margins are smaller than method 1 effectiveness values, but the maximum reduction is only 1.71%, which is almost equal to nothing. On the aspect of the outward coverage, compared with using the method 1, the method 3 could improve outward coverage value for 85% of patients, which is 11 out of 13 patients, and except patient 1 and patient 4 over here, using the method 3 could increase maximum 14.7% and average 7.48% of the outward coverage. Moreover, if we rank all the patients according to the original coverage, it's not difficult to find that the improvement of the outward coverage values using the method 3 will increase as the patient's original coverage value decreases, which means in the area over here, the improvement of the method 3 actually is larger. And this indicates that method 3 could greatly increase the outward coverage value for patients who experience a relative huge rectum wall outward displacement. And we also did the same process for the comparison between the method 2 and the method 3. The result is quite similar, only the improvement of the method 3 is smaller. So we can see as so far, the method 3 is the best method in this project. So we generate 13 different PRV margins based on the method 3, and we name these PRV margins according to the name of the rectum region. And as you can see, we modulated all the PRV margins. In this way, we could generate the combination margins by just combine the margin from 3 different rectum regions together. So we generated 3 different combination rectum PRV margins over here. Is combined with superior part of rectum PRV margins, middle part of rectum, and lower part of rectum PRV margins. All 3 margins has its own aim and its own size, all in centimeter. Then we performed the validation process for these 3 PRV margins, and the result actually is quite impressive. We are pretty satisfied with it. Figure here shows the DVH of two bladder PRV margins, PRV2, the yellow one, and the PRV5 is green one. So two margins share the similar dose distribution. The peak of both bladder PRV margins curve occur approximately at 300 Sigri over here and 8,100 Sigri over here. So this indicates the necessity of applying the PRV margin to the bladder, because we can imagine that with all the PRV margin, the bladder may well experience these two peaks in the real radiotherapy treatment, and this may will increase the possibility of patient have a side effect. Figure here shows the deviation of two rectum PRV margin. One is created through using the methyl 1, which is the blue one. Another one is through using the methyl 3, which is the green one over here. And this one is also indicates the necessity of applying rectum PRV margins to the rectum in the radiotherapy, because there are also many peaks over here. In this project, we also conduct an investigation about the comparison between the Fiducial marker-based image fusion and Bony landmark-based image fusion. As we can see, for the Bony landmark-based image fusion, the bladder wall displacement in the posterior direction is bigger than using the Fiducial marker-based image fusion, which means the Fiducial marker-based image fusion is better, because in the prostate cancer radiotherapy, we always want the bladder have a smaller displacement in the inferior and posterior directions. At that direction, that is the area of the GTV, which is the prostate and the high dose region. And of course, this project has tons of problems, such as a contouring error is caused by the low CBCT image resolution, and measurement error is caused by manually measurement procedure, and image fusion error is caused by the position shift of the Fiducial markers inside the prostate. And this position shift will make it difficult to make the image fusion. And we believe the best way to solve this problem is using the machine learning or other computational method, because all the errors actually is created through the procedure which conducted manually. So the computational method probably is better. And hopefully the machine learning could solve all the problems. This project is ended pretty hurry. It's really pretty hurry, and I'm gonna blame everything on this coronavirus. If there is any other reason, probably because I spent too much time on the contouring and measuring this project, it kind of delays the progress of the project. But overall, it's a really fantastic project, and I really love it. And I want to thanks to all my supervisors over here. It's handsome, and I also want to give my thanks to Dr. Beachman for helping me a lot in the past 2 years. And I also want to give my thanks to Genesis Care and UWA Medical Physics Research Group. Actually, as long as in the past 2 years you didn't hurt me, I want to give my thanks to you. And it's it. Thanks, everyone.
Okay.